Today we have Dr. David Levett, who is one of the experts on stone disease, working at Vattikuti Urology Institute, Henry Ford Hospital, Detroit. Thank you, Dr. Levett, to have accepted to talk about stone management.
Thank you.
Stones are very common, and I think over past 3 decades, the management has really revolutionized from the open stone surgery. It ranges from no treatment to most radical treatment. Would you like to tell us something about how do you see the landscape of stone management has changed over past 3 decades?
I think you're absolutely right. We've seen a big change toward more minimally invasive or less invasive surgical options for many stones in places where the resources are available. For smaller stones that don't seem to be affected kidney function or infections, we sometimes actually will watch these. And similarly, the advent of shockwave in the early 1980s still plays a prime role, but more often in the last probably 5 to 10 years, we've seen an increase in endoscopic procedures, so cameras and scopes that are placed into the urinary tract to try to eradicate the stones. This can be done either retrograde or from the urethra up into the kidney where there's no incisions, or this can be done minimally invasively now across the skin, coming into the kidney from the outside world, and that can be done with a variety of different sized cameras and scopes, just depending on the availability of instruments and the expertise of the operating surgeon and the specific characteristics of the patient's stone disease.
One common question a patient of stone has that what are the early indications? They always ask you, could I have avoided having this problem?
And a lot of times this is found after the fact. They often will form sort of silently, and then once they're there and large enough to cause a problem, you start to see this. So many times it's after the first stone we get some indication to be more preventive for these individuals. As a general rule, it's oftentimes an effect of dehydration or relatively not enough fluid getting to the kidneys, and all the microscopic crystals in the urine set up a nidus or an area for more stone growth. So as soon as we've seen someone with kidney stones, we always want to be very aggressive about trying to prevent future ones, since depending on sort of which study you look at, as many as 50 or even 70% can have a repeat stone event in the next decade or so.
What are general measures a patient who has already had a stone should follow to prevent the recurrence of stones?
If resources are available, a lot of times we like to start with urine collection, a 24-hour urine, just to get a better sense of the patient's individual risk factors. But short of that, or if you're not able to do that, some general recommendations that seem to fit almost all stone formers are considerably increase in their fluid intake, as much as maybe 2+ liters of urine a day output, not just input, but output, so how much you're actually urinating out. General rule, you want to limit salt in the diet, and you also, sometimes some of the other heart healthy things that we talk about, you have to be a little more careful in some high-risk stone formers, because some of the what we call oxalate contents can increase your stone risk. And oxalates can be found in a variety of different things, and sometimes it actually changes based on where the food comes from, the soil you have. So it's an incomplete knowledge on our end, but no doubt all these things come into play. We haven't found just one gene or one specific target.
Is it possible for stones to damage kidney without making any noise and just suddenly patient presenting in kidney failure?
So unfortunately, we see this more than any of us would like. You can see this in a few different scenarios. One of them we'll see is very large stones that we believe silently fill up almost the entire inside of the kidney. Sometimes these are called staghorn stones, and over time you can find that these will ruin the filtering and the functioning of the kidney. Another scenario we'll see is sometimes smaller stones that may cause the entire kidney to be blocked. What we call the ureter is the drainage tube from the kidney. If a stone is impacted or gets in there and it either isn't treated in a timely manner, or if the patient doesn't have typical pain and blood in the urine type symptoms, and so it's not known, over time this can silently ruin a kidney as well. Those are common areas we'll see this in.
Is there any minimal or what percentile danger of developing cancers with stones?
There is a minimal risk of having cancer, and the most common scenarios we tend to see that are stones that have been there for many, many years or many, many months that are left alone. The belief or the thought is these chronically irritate the inside of the kidney or the ureter. They cause some changes at the cellular level that can lead down a path to eventual cancer transformation. This is rarely seen for stones that haven't been there for too long, but you can see this if the stones have been there for many, many months or years, we believe.
You have given a very elaborate and clear account of current status. Could you tell us something about what are the future horizons you expect in the stone disease?
I think the ultimate goal, I think, for any surgeon or anyone that treats stones is if you can actually do a better job preventing these. We've been using the same set of medications for the last 30, 40 years with not much change, and one of our strongest recommendations still remains just increase how much fluid you take. So there's a whole lot of work, I think, from a preventative standpoint that needs to be done. From a technological or a procedural standpoint, I think there is a push toward continued minimally invasive approaches, and you've seen even less invasive sort of surgeries that come across the kidney, and I think we'll see more of those since you usually get similar stone clearances, similar good outcomes for patients, but with less of the risks. And then more recently, too, you've seen the infiltration of robotics into the stone environment, and there's a robotic ureteroscope platform now, or one of the small flexible cameras we use to go into the kidney. This takes some of the control out of the surgeon's hand in a way and automates it, and a lot of processes similar to maybe the robot being used for other cancers that we see, this may ultimately lead to better outcomes. So there is forefronts there. And the last one, or at least another avenue, there are some belief, what we call microbubbles. And the idea is if there's some way to target or deliver some of these directly to the stone, per se, you can sort of focus, say, your shock waves or a different level. So many exciting avenues, still a long way off, I'd say, before we're doing the best we can for the patients.
One common question a chronic recurring stone disease patient has is that during the lifetime of his stone disease, he has to go through so many imaging investigations. You think that could cause radiation itself could cause some problems? And if so, what would be your advice to younger urologists how to avoid radiation when you know that you said the recurrence chances are very high in these patients? And that is something we as surgeons should anticipate and do something rather than later on they're developing leukemias and things like that.
I think the radiation exposure, you're absolutely right, is a necessary, I'll say, evil that we use on a daily basis a lot of times, and everything you can do to reduce that is good for everyone, patient, you as the operator, other people, personnel in the room, especially for the younger patients where they sort of have shown a pattern of stone disease. Oftentimes when they have an acute attack or a kidney stone or a ureteral stone attack, it follows a similar pattern, or they sort of recognize this appears to be another stone. And I think as a physician standpoint, our gut response should not be just to send them for another CAT scan or a radiation scan. Some of these people, if they're overall comfortable and doesn't appear to have any renal failure, you may be able to watch for a time to see if they pass the stone. You can also use, I think, ultrasound, and I feel that should be used more and more commonly as the technology improves. Our ability to determine stones, etc., gets better. Ultrasound right now can be limited in adults based on how large some of the patients are, some other factors where they work much better in the younger patients. So as a general rule, I think if you're a known kidney stone former, you're having what seems to be a kidney stone attack, sometimes the ultrasound is the first place to start, and it gives us a sense how at risk or at damage your kidney may be, and that can dictate or indicate further radiation. Lastly, when we do the procedures, I think if we integrate more ultrasound and we be more mindful of how much radiation we use, a lot of times you can do a procedure just as successfully with a significantly reduced dose to the patient just by changing some of the parameters or settings on our instruments to produce the radiation during the surgery.
Thank you very much. It was a very valuable information, and I appreciate your time for that. Thank you.
Thank you for the opportunity to share.